Everybody, it's a pleasure to be here at this capsule, and it's a pleasure to have those that have come this early in the morning. So I'm going to talk to you about management of diabetic macular edema and a bit of do's and don'ts there. So, the management of DME has moved from the erstwhile laser photocoagulation in the 80s to the turn of the millennium, where we had steroids coming in, and then to the current era of intravitreal anti-VEGF, which basically bevacizumab, ranibizumab, and aflibercept hold the fort. So the approach I'm going to take is to look at the current basic principles governing DME treatment, look at the factors that need to be assessed, and letting us know how to strike thereafter. So RESOLVE clearly showed us that ranibizumab had very high efficacy versus sham. DRCR protocol, I went further and looked at the different modalities available. The ranibizumab laser in combination arm was shown to be decidedly better than laser or IVTA laser, and that differing combination laser was better than doing prompt laser. As is seen in this 2-year equity plot, where the combination arms with ranibizumab did far better than laser only or IVTA and prompt laser. So the first thing is anti-VEGF injection should be a first option. The second thing is avoid putting in prompt laser, and prompt laser and IVTA are no longer first up options for us. So the equity plot at 3 years and at 5 years showed an advantage for deferring laser in this combination, and so with the reduction of macular edema, where again deferred laser was better. Early intense treatment reduces treatment burden later. This is something very important that came through, as you can see in this plot. In the first year, in both the arms, 8 and 9 injections, and then subsequently drops off dramatically to 2 and 1 and 3 and 2 injections in the subsequent years, which seems to suggest that it's important to get a grip on the disease earlier. Do not hesitate in being intensive with your treatment upfront. Something you should share with your patients. Tell them that if we go early hard, then subsequently it becomes easier in the following years. And diabetic macular edema is not a one-off disease. It's going to be a chronic affair, so we need to be like that. And up to 43% of patients really required no injections in year 3. Then higher safety issues were noted for IVTA in terms of elevated intraocular pressure as well as cataractogenesis. So higher safety issues are an issue. Rice and Wright showed us something very important, that in untreated eyes, it's never too late for anti-VEGF therapy, and chronicity is not as big a deal as we sometimes make it out to be. So you see here in this plot, equity plot, you see that the sham arm did not get off the baseline up to 2 years. So for 2 years, these patients carried that amount of macular edema, and the moment they were open or fed with Lucentis, the equity plot almost magically starts snaking up. And the same likewise seen with the macular edema. The moment these patients were given Lucentis, it started drying off. So do not hesitate in treating chronic DME if there are no degenerative signs around. Restore showed us the same thing with lasered only eyes. Again, never too late for anti-VEGF treatment, chronicity not a big deal. And that secondly, counterintuitively, adding laser didn't seem to reduce ranibizumab retreatment rates, which we think is the USP for laser. As is seen in this plot here, so you see that blue line at the bottom, that was the laser-only arm. For 1 year, these patients had only laser initially and nothing else, and you see it hardly improves. And then moment Lucentis was given to these patients, you see that equity starts picking up. And at the end of 3 years, lo and behold, it actually catches up with the combination arm. The corollary to this is that it doesn't seem to make a difference whether you add ranibizumab to the laser 1 year after laser or immediately at the start. At the end of 3 years, they end up at the same time point. So the key is, do not hesitate in treating, don't hold your hand in treating DME even if it appears to be chronic. And this shows that the number of re-injections were the same in all the treatment groups. So adding laser doesn't necessarily reduce your re-injections. Bolt and Vista showed efficacy for bevacizumab and aflibercept respectively, and it was DRCR-T, protocol T, which compared these 3 modalities, these 3 injections, and they gave us 2 clear messages, that there was definitively higher efficacy for aflibercept and ranibizumab over bevacizumab in poor vision patients, that is less than or equal to 25/50, and secondly, of the 3, bevacizumab clearly reduces macular edema the least. So this equity plot shows the same thing, aflibercept and ranibizumab being better than bevacizumab in the poor vision patients, and it also reduced macular edema the least. So these are the regimens now. How do we dose? Monthly dosing, PRN, and then treat and extend came in. And of course, we know monthly dosing is not practical. There's risk of infection, huge economic burden, time, though it is the most effective. PRN is very strict visual acuity and OCD-based criteria. So the RETAIN study was the first one which really did a head-to-head study of treat and extend versus PRN, and they found that at the end of 2 years, there wasn't really any significant difference between the 2 regimens. Beaverdex study was the first which did a head-to-head comparison of Ozurdex and bevacizumab, about 88 patients. You see on the left, the equity plot at 2 years shows that bevacizumab did better than dexamethasone. But then, if you look at the subset of patients which are pseudophakic, they were more or less similar. When you look at the mean central macular thickness, interestingly, it finds that dexamethasone seems to reduce that macular edema the most and fastest. And at 1 year, it did better, but at the end of 2 years, it was more or less the same. So Ozurdex can be an option in pseudophakic patients. So this is a treatment mantra, monthly anti-VEGF injections until the patient is stable, which means equity and OCT more or less unchanged over 2 to 3 visits. And then you can go in for wait and extend or treat and extend. Wait and extend if you have mitigating factors like a bit of degeneration and stuff, and you don't want to be very aggressive, then you can extend follow-up up to 2 months. But if the edema is still clean, then you may go in for treat and extend. And then up to the point where it's stable, and then you extend follow-up up to 3 months. If it still remains unstable, then you go back to treat and extend. So if the dosing is inadequate, you would do that. If dosing is adequate, you've done a lot of injections, then you can switch it, move from Avastin onto Accentrix more commonly, or vice versa. So this is a patient who benefited, was refractory to Avastin after many injections, and then benefited with Accentrix, and the opposite was also true, but less commonly. So switching in drugs in refractory cases is useful, and this was also seen has now been corroborated in various studies which have switched drugs between ranibizumab and aflibercept. So elderly pseudophakics, IVTA is an option. Ozurdex comes into its prime really in vitrectomized patients, as seen in the study by Boyer et al., who showed a definitive advantage of Ozurdex in post-vitrectomy diabetic macular edema patient. In this situation, Ozurdex is the only one which retains its pharmacokinetics, and so this is one place where it really holds a primary role. So that's number 15, it's vital in post-PPV DME. Then, the MEAD study sub-analysis showed that dexamethasone had great utility in refractory DME cases where all other options have been tried. Then came the question of combining anti-VEGF treatment with steroids. Does that help? So Protocol U answered that question when they found that adding dexamethasone to ranibizumab really offers no significant advantage, and in terms of equity, though macular edema reduction was there. Sohail and Wang showed that adding IVT to Avastin offered no significant advantage. And this is another thing that again was looked at. What about the background effect? We are focused on the macular edema, but what about the background? So there are enough and more studies now which show that repeating anti-VEGF also benefits the background diabetic retinopathy status. So that's something you can also share with your patients and motivate them to pursue anti-VEGF treatment. So in essence, finally, ERM vitrectomy, obviously one should keep an eye out for those surgical conditions, the vitrectomy to be done there. Future directions, subthreshold micropulse lasers coming in. People have had mixed experience with this. Iluvien is a great option for chronic edema. It's expensive. It's still not come to the market. We look for that. Ocriplasmin, Fasudil, ALG, Lunate are all things which are happening in the background. Other alternatives that have tried increased frequency of injection, dose hike, drug cocktail, drug holidays, and limited vitrectomy with or without eye length peeling. So these are all the options that we have. Thank you.